Hello, everyone. I'm Devin Bernard with AOPA, and I am the Assistant Director of Coding, Reimbursement, Education, and Programming. Presenting alongside with me today will be Joe McTurnan, the Director of Coding, Reimbursement, Education, and Programming for AOPA. Thank you for joining us for a quick review of the upcoming implementation of the Medicare prior authorization process for a select number of lower limb prosthetic HCPCS codes. Today's presentation and review is going to be divided into three parts. First is a quick history to show how we got where we are today. Second is a review of how the prior authorization process will work once it's implemented in September and December, depending on where your patients reside and where your offices are. Then lastly, we will go over some tips or pointers on how you can get ready for prior authorization, and this will include some tips on documentation and working with your referral sources and your patients. Before we kind of get started, do you have anything else you want to add, Joe?
Thanks, Devin. Glad to be here today. Just wanted to add that it's important to remember there are actually 2 dates going on, and we'll cover this during the presentation. But the program will be rolled out initially in 4 states, what we call the pilot states of Pennsylvania, Texas, California, and Michigan. That rollout is scheduled for September 1st. And then the program is scheduled to roll out nationwide on December 1st. Everything you're going to see today will apply to both the initial implementation and the national rollout. So please, Devin, continue.
All right, thanks, Joe. First up is a quick review or history of the prior authorization program for DMEPOS. It all started with the Medicare prior authorization of Power Mobility Device Demonstration Project, which began in about 2012. The project established a prior authorization process for select power mobility devices, but only in 7 states, California, Florida, Illinois, Michigan, New York, North Carolina, and Texas. Based off the early results of this demonstration project, monthly expenditures for the devices selected showed a decrease, and there was no reported reductions of errors or issues in beneficiary access to the medically necessary items. So at that point, CMS extended the demonstration project to include an additional 12 states for a total of 19, and then at the same time also proposed to establish a prior authorization process for other certain DMEPOS items that are frequently subject to unnecessarily utilization or errors, and that brings us up to the next phase. So in May of 2014, CMS published a proposed rule that would allow certain O&P items to be subject to prior authorization if it was shown that the items were subject to unnecessarily utilization. To determine what would be subject or possibly qualify, the proposed rule created a master list of HCPCS codes, and only those codes on the list could possibly be subject to prior authorization in the future. Now, to be included on this master list, a code or item had to meet specific criteria. First, the code must be part of the DME POS fee schedule, so it must be a valid code. It had to have an average purchase price of $1,000 or higher, or an average monthly rental rate of about $100. And the item or code had to have been identified in a report from the U.S. Government Accountability Office or the Office of the Inspector General as having a high rate of fraud or unnecessarily high utilization rates, or the item is listed in the comprehensive error rate testing or CERTS annual Medicare fee for service improper payment rate to Medicare each year. Over about a year and a half later, CMS then released the final rule. It gave us a first true glimpse into what codes may someday be subject to prior authorization, and also laid down some other key groundwork as into how the program and the process would work. The final rule established the master list of HCPCS codes that are going to be eligible for inclusion into the prior authorization program. And that list consisted of about 135 HCPCS codes, 84 of which described lower limb prostheses. There were 5 prosthetic codes that were removed from the initial list of 89 from the proposed rule because they didn't meet all of the established thresholds, and those were things like the prosthetic covers and skins. The final rule also kind of laid out that CMS would not include all 135 codes in the initial implementation of the program or the ways of it. Instead, it was determined that CMS would publish a subset of the 135 codes that would be subject to prior authorization, and CMS referred to the sublist as the requires prior authorization list. So the require prior authorization list is a subset of that master list. The rule also announced that following any announcement of something being placed on the requires prior authorization list, there would be a 60-day notice period prior to the implementation of prior authorization. So once something is placed onto the requires prior authorization list, there is a time frame which it is released and made aware to everyone so that there's time to adjust and get ready. The final rule also announced that implementation of the prior authorization program could occur at the local level or a regional level instead of being rolled out nationally. So in other words, it could be done in phases instead of being done all at once. None of the 84 possible prosthetics codes were included on any of the subsequent required prior authorization lists between 2015 and 2019. The lists released during this time period primarily included DME items such as like power wheelchairs and pressure reducing support surfaces, and things along those lines, but did not include any orthotic items or any prosthetic items. In July of 2019, CMS released a large multi-encompassing proposed rule which covered things like the creation of the new standard written order, updated the face-to-face requirements. It also included ideas and concepts or new rules or ideas for updating the prior authorization program and process, including lowering the average price threshold. So in other words, changing that $1,000 threshold. On October 31st of 2019, CMS released the final rule, which became effective on January 1st of this year, and it did lower that average purchase price from $1,000 to $500. This reduced threshold for inclusion now means that that list of eligible codes for the master list greatly expanded. It's now 226 O&P HCPCS codes are eligible to be included on that master list if they meet all the other criteria, meaning they have the high rate of fraud or unnecessarily high utilization rates, and have been targeted or subject to cert audits. This also meant that the list of prosthetic codes went from about 84 to about 132. So almost every single lower limb prosthesis code, their prosthetic code, is now on the possible list of items for prior authorization. So the list has greatly expanded. The final rule also once again stated that there would be a 60-day notice period before the program would officially begin once a code is placed on the requires prior authorization list, and that the program may be rolled out in select areas or may be rolled out, on a unilateral national level or basis. With that expansion of the HCPCS master list, it was assumed that a new requires prior authorization list was around the corner or was going to be released or updated at any time. And it was on February 11th, 2020, 6 lower limb prosthetic HCPCS codes were added to the requires prior authorization list because they met all the established criteria. They are listed on the current HCPCS fee schedule. They are valid codes. They are listed as having an average reimbursement of over $500, and they are codes that have been subject to recent OIG or CERT reports. The 6 codes are microprocessor knee codes, the L5856, the L5857, and the L5858, along with the microprocessor foot code, L5973, also the 5980 or the flex foot system code, and the 5987, the shank foot with vertical loading pylon. Now, the February 2020 announcement also kind of laid out or presented the initial timeline for when prior authorization would begin and where it would begin. The prior authorization project was to be rolled out in 2 distinct phases. Phase 1 was to occur in 1 state in each of the 4 DME MAC jurisdictions. So Pennsylvania for jurisdiction A, Michigan for jurisdiction B, Texas for jurisdiction C, and California for jurisdiction D were the ones selected, and the program was to begin on May 11th of 2020. So they started out, with a small rollout, that local or regional rollout, and then switched to phase 2, which would then be that rollout to all the remaining states and territories, was to begin on October 8th of this year. CMS decided to take that 2-phase approach to allow them to identify and resolve any unforeseen issues or things that might have popped up during that implementation process. As you know, these are not the current implementation dates, but they were to be the intended implementation dates. So, theoretically, if all things were going according to plan, we would have been well into the prior authorization process at this juncture in time. Before prior authorization could be implemented, CMS in March suspended the program due to the COVID public health emergency. It was believed that the program would be suspended for the duration of the emergency. However, in early July, CMS stated that the prior authorization program was to be re-implemented as soon as possible. They said, given that the importance of medical review activities to the CMS's program integrity efforts, that the program will resume in August. However, the prior authorization for the 6 lower limb prosthesis codes would begin in September. Now, specifically claims with a data service on or after September 1st of this year for California, Michigan, Pennsylvania, and Texas, and then on December 1st for all remaining states and territories. The prior authorization operational guide or manual has stated that the DME MACs will begin to accept prior authorization requests on August 18th in anticipation of that September 1st start date, and on November 17th for the anticipated December 1st start date. This will allow for the processing time for any items being delivered on either September 1st or on December. So to kind of stress the point, if you have a patient living in California, Texas, Michigan, or Pennsylvania, or your offices are set within one of those 4 states, and you plan to deliver a completed prosthesis that includes one or more of those 6 codes on or after September 1st, you may want to submit your prior authorization request on or after August 18th to ensure that there are no delays in delivery and billing. So as we get closer to that September date and you anticipate deliveries on or close to that September date, you may want to start the prior authorization process as soon as possible. All right, so that kind of brings us to where we are today. So that's a quick history and recap. Before we head on to the second part of the presentation, do you have any additional comments, insight, or anything you'd like to interject, Joe?
Just one very small point and a small correction, Devin. The slide actually here reads December 8th as the implementation of phase 2. You said it correctly in the presentation, but the date for implementation of phase 2 is actually December 1st of 2020. So just wanted to make sure that that's clear and that was just a slight typo on the slide. So, but nope. Otherwise, nothing to add so far.
Thank you, Joe. And I apologize, everyone, for that. I should have caught that prior. Okay. So how will the prior authorization process work? Based on the final regulations, a prior authorization request or PAR must be completed prior to both delivery to the beneficiary and claim submission. So the final prosthesis cannot be delivered until a prior authorization decision has been made on the codes we mentioned. So if you determine that you will be providing one or more of the 6 codes, your first step is to submit a PAR and seek a positive affirmation indicating that the codes in question are medically necessary. The first step in submitting your PAR is to obtain all the proper content or general documentation and fill out all of the correct forms. This would be starting with the completing of the prior authorization request cover sheet from your DME MAC to indicate things such as patient information, their name, their MBI number, your information such as your MPI and PTAN, your address, your contact information, and lastly, listing out the code or codes you are requesting a PAR request for, and also indicating if this is going to be a resubmission, an expedited review request, or just your traditional normal everyday prior authorization request. And we'll kind of talk about those different requests as we go on throughout this presentation. Each of the DME MACs have their own cover sheet, and you can kind of see what they look like here on the screen. So, on your Noridian site or your CGS site, you can go ahead and get a copy of these and download them to kind of take a look at them. Here are the cover sheets in a little bit more detail. As you can see, they're pretty similar. I kind of want to point out that the forms do have links to helpful web pages and documents such as the LCD, the policy articles, documentation checklists. There's even a checkbox on there, a check form on there to verify that you've included all the information that you need. These items, these checkboxes, these links are here to kind of help you out. So you may want to review them or take advantage of them until you become 100% comfortable with the Medicare prior authorization process, as it may be a little bit different than you might be used to or normally working with your other payers. So kind of when you take a look at these forms, take advantage of those items they've provided for you. There's other information or content which must be submitted along with your cover sheet. You also have to submit all supporting documentation from the medical record and documentation required by Medicare policy to demonstrate medical necessity and coverage, and to show that coverage criteria has been met. According to the final rule, this documentation would include a valid standard written order For a SWO to be considered valid, it must contain 5 key elements: the patient's name or their MBI number. It must have an order date. It must have a general description of the item being ordered. This could include the listing of codes and or scriptors or a narrative. You don't have to provide information on the exact names you're providing, such as model numbers or product names, unless you already know that information and you know what you'll be providing, because remember, this submission's coming prior to your delivery. You also need to include a description, just a brief description, and that's all you kind of really need. You also have to have the referring physician's name or their MPI number. And then lastly, you must be sure that you have their legal, legible signature on there as well. So the first thing you're going to submit beside your PAR cover sheet is the SWO. The final rule also says the required documentation to be submitted would include all relevant information from the beneficiary's medical records, such as physician's documentation, therapist documentation, hospital documentation, facility documentations, statements on the desire to ambulate, and any other relevant supplier-produced documentation and records, such as K-level evaluations or assessment forms and things along those lines. Remember, your notes may be used to justify medical necessity and can be used in this determination process, but they must also corroborate and work with or build upon what is in the existing physician's medical record as well. Once you've gathered all the required documentation and completed the PAR cover sheet, the next step is to submit your request for review. You have 4 options available to you. However, you're probably most likely only going to use one of the 3 methods, probably either faxing or mailing or your DME Max web portal, or you could use the ESMD if you do have that type of system set up. If you use the DME Mac portals, remember you're going to have to first register with your DME Mac through their websites to sign up and use them. These are those portals that you are probably using already for your reopening requests or to do checks on same or similar, or to check on status of the claims. It's going to be the same type of portal. If you use the portal, you may fill out those cover sheets online, so you wouldn't have to print them out and fill them out separately. So that kind of saves you a little bit more time if you use that portal. It's important to kind of select and use a method of submission that you are comfortable with, and the method that you prefer to receive future information on, as the method you choose to submit your request is also going to be most likely the method in which the DME Macs are going to communicate additional information to you about your PAR request. So use a method that you're comfortable with using and one that you are familiar with. Excuse me. Once the prior authorization request and all supporting documentation is received, the DME Mac will review the information and make a determination. With your initial request, the decision should be made within 10 business days, not 10 calendar days, but 10 business days from the receipt of the information. So not the receipt of your submission, but from the receipt of the information that they receive, and it's those 10 business days. It could be sooner, but it may not be longer than those 10 days. After your prior authorization request is reviewed, the DME Mac will send you a response letter or response correspondence informing you of the results, either being affirmative or being non-affirmative. The response will also provide you with a detailed explanation for their decision. So it's not just they say yes or no and leave it at that. They will provide you with the rationale that guided their decision. The most important item included with your correspondence will be a unique tracking number, or UTN or UTIN, and this UTN will be needed when you submit your claim. In other words, you will not be able to proceed unless you have and you include this UTN number. It is your proof that you completed the prior authorization process, or without it, you cannot proceed to the next steps or the next level. So it's very important that you do not lose that UTN. It's also kind of important to note and point out that the address that DME Max will use to send you your decision letters will not be the address that you provided on your PAR cover sheet, but rather it's going to be the address on file with the National Supplier Clearinghouse for your MPI and PTAN. So before, so you want to be sure your mailing information is correct with the NSC and you know where the mail is going, especially if you have multiple offices, but you're using one central billing location. So you may want to go ahead and kind of check on that to make sure that the NSC has your proper mailing addresses on file. If you received an affirmative decision, meaning your documentation supported medical necessity and coverage criteria, you may submit your claim for payment as you normally would. The only difference is that you would now submit your claim, you must include that UTN number, because any claims that are submitted without it will automatically be denied. If you're submitting a paper claim, the UTN number would go into the first 14 spaces of box 23 on the CMS 1500 form. If you're submitting a electronic claim, you'll want to check with your software or clearinghouse provider and verify which segment or loop of the electronic claim will correspond with section 23 of the paper form. Depending on the type, it's either going to be the loop 2300 segment or the loop 2400 segment. So you want to verify with your clearinghouse and billing provider of which one should be used. It's important to point out that after receiving an affirmative prior authorization, it's not a 100% guarantee of payment. It's probably that 99% guarantee, but it's not a 100%. It is possible your claim could still deny for a technical reason, such as using an improper data service, entering incorrect numbers of units on the claim, not having a proper or valid proof of delivery on file, or patient is in a facility, or anything else that may have occurred after submitting your prior authorization response. Another example of this could be, the item that you provided was not PDAC approved or listed on the PDAC website. We'll kind of talk about that requirement a little bit later, as it's not a current requirement, but it will be something in the future. You would also likely not receive any not medically necessary denials, as that's what the PAR is for, or PAR covered, but you could receive that technical denial. Lastly, a positive PAR affirmation will guarantee payment, and it will reduce the likelihood of future audits. But please keep in mind that you may be subject to things like a CERT audit, as they are used to check up on the contractors processing the claims, and those are random. So there is a very small chance or slight chance it can still be audited, but it's very unlikely once you receive those that prior authorization positive affirmation. Once you received your affirmative PAR response and UTN or UTN number, the clock starts ticking. The PAR does have an expiration date. You must deliver all items and services associated with your PAR request within 120 calendar days. If you miss this window, you must resubmit your request again and receive a whole new affirmative decision letter and UTN number. So you have 120 days, 120 calendar days to finally fit your patient and deliver the items that you received prior authorization for. If your PAR was denied and you received a non-affirmative decision, meaning your documentation did not support medical necessity and coverage criteria, you have a few options. First, you may review the decision letter to address and resolve the reasons provided and resubmit. You may not appeal the non-affirmative decision, but you can fix the errors or discrepancies or obtain the documentation that was lacking or laid out to you within your detailed decision letter. Now, a PAR can be resubmitted an unlimited number of times until all the problems are resolved and fixed, and you receive that positive outcome, and then you proceed as you would. Also, it's very important to stress that the turnaround time for the MACs to process a resubmitted request is 10 business days, just like the initial request. This is kind of important because under the initial final rule and with other prior authorization programs, that turnaround time for a resubmitted PAR could have been up to 20 days, but now it is set at 10. And once again, you can resubmit as many times as you like until you get your desired outcome. You may elect to bypass the PAR resubmission process and submit your claim for payment. This could be because you are going to a secondary payer, or you feel that the information you have on file is strong enough for you to win on the appeals process. The code or codes in question will be denied, and you will be liable for that denial. However, you have your appeal rights available to you, and you can proceed through the 5 levels of appeal. If you choose this option, when you submit your claim, don't forget to include your unique tracking number on the claim. Remember, without it, the claims will not process. They are denied. Option 3 is very similar to the second option, but one major difference. You may inform the beneficiary of the non-affirmative decision and have them sign an ABN and then submit the claim that way. The code subject to the prior authorization request will still be denied and will still remain appealable. However, the beneficiary will now be the one liable instead of you. If you plan to use an ABN, there are some things you should keep in mind. First, you may not use an ABN to bypass the prior authorization request process. In other words, you cannot have the patient sign an ABN at the onset and not obtain a tracking number or submit the PAR and wait the 10 days for response. Also, before you have a beneficiary sign an ABN, you must obtain that non-affirmative decision and unique tracking number. Also, just as all other normal billing rules and requirements apply to your claim, so do the rules for providing a valid ABN. So you must make sure you are completing the ABN properly and providing the patient with enough time to review the ABN and make an informed choice. As you recall, one of the requirements for a valid ABN is to have a specific reason for why you believe the claim will be denied is not medically necessary. The rationale for your belief why the claim would be denied should match the information you received from your detailed response letter from the DME-MAC, as they kind of provided you the exact reason why they would be denying the claim. So use that as your exact language. Once again, and as always, when you submit your claim, be sure you include that UTN or unique tracking number. And this time around with option 3, you would be sure to include the GA modifier as well. You or the beneficiary may request a expedited review when the standard time frame for making a prior authorization decision could possibly jeopardize the life or harm the health of the patient. In these rare situations, you must include rationale supporting the need for your expedited review or an explanation as to how waiting 10 days would jeopardize or harm your patient. In these circumstances, the DME-MACs will make a reasonable efforts to communicate a decision to you within 2 business days instead of 10 after receipt of all the applicable Medicare required documentation. As for the prior authorization process or program, is typically for non-emergent services. an item CMS request is expecting there to be very few of these expedited requests, but it is possible for you to do one if you can show that there is potential harm to your patient. After the 2 days are up, all other steps apply, such as getting your detailed response letter and your unique tracking number and sending in your claim for payment. However, your communications will be closer to real time, so no mailing to wait for. They'd be done by emails, phone calls, or faxes. All right, so here's a quick recap. Complete the prior authorization cover sheet for your lower limb prostheses from your DME MAC. Submit the cover sheet and all supporting documentation such as the standard written order, physician records, prosthetist notes, and any other additional records that you feel support medical necessity for the review. The submissions may be done via fax, mail, or through DME MAC established portals. Within 10 days, you'll receive either an affirmative or non-affirmative decision and a unique tracking number with a detailed letter explaining the results. If you received a affirmative outcome, you may submit your complete claim for payment and be sure to include your unique tracking number on the claim. That PAR request and unique tracking number will be valid for 120 days. If you received a non-affirmative PAR, you may attempt to fix any errors and resubmit it. You may also elect to submit the claim straight with the UTN. However, keep in mind in those instances that the HCPCS codes in question will be denied. What about not submitting a PAR? As we kind of said, that's not an option since the submission of a PAR is now an established criterion for payment, meaning no PAR, no payment. Claims for items on the required prior authorization list submitted without a prior authorization request determination and corresponding unique tracking number will be automatically denied and rejected. In addition, this automatic denial does not come with any appeal rights, meaning you have no way to obtain Medicare, payment from Medicare without those. All right, so that kind of ends the second part of that presentation here, how the processes work. So before I hand it off to Joe to kind of go down the home stretch, is there anything you'd kind of like to add or include or clarify, Joe?
No, I think you covered the process very well, folks. This is a new process. This is one that is not going to be without its challenges initially, but I think what we can take from the experiences of our colleagues in other industries is the process is actually working fairly well, and there's been some general happiness with the program in other areas. So while there's some trepidation about prior authorization as a concept and as a program, the DME Macs have done a pretty good job of handling the logistics of the prior authorization process and meeting their self-imposed deadlines of 10 days to get these decisions out there and to prevent delays in patient care. So we are very hopeful that this will continue as they expand this program into lower limb prosthetics. Hopefully they will learn some valuable lessons from the initial rollout in the 4 states that they will use to improve the program once it gets a national rollout. So with that, I am going to go ahead and take control of the session here. And let's move on to some tips and some thoughts on how to get ready for the reality that is Medicare prior authorization. And like I said, folks, this is something that is a program that is not it's not likely to be reduced in the future. It is more likely to be expanded in the future. So our goal is to help you understand the process and give you the tools you need to make it a successful tool in your business, as opposed to a potential burden in getting patients the care that they need. So let's talk for the next few minutes about what you can do to make sure you are ready and to make sure that your systems are in place and that you're doing what you need to do for a successful outcome with prior authorization. So the first thing we need to talk about is documentation. So like any service that you provide, documentation is really one of the keys to providing good quality service and making sure that you maintain the ability to be reimbursed for the services that you're providing. You should not be making massive changes to your documentation procedures as a result of prior authorization. This really is a function of when the decision will be made about coverage as opposed to what decision will be made about coverage. The rules haven't changed. The same documentations that requirements that are in place now will be in place in a prior authorization environment. They simply will just be brought into the process at an earlier stage, and frankly, at a stage before you may have laid out your own company's resources to purchase components without the knowledge that they may not be considered medically necessary for your patient. So there are some good parts of prior authorization that can be seen as valuable. But remember, your notes are expected to corroborate and provide additional details that are present in the medical record of the patient from the physician's notes, from other providers' notes, and your notes alone, while are now contributory, are not going to be sufficient solely on their own to show the medical need for the services that you're providing. So you want to make sure that you are creating consistent, repeatable processes to make sure that your claim has the best chance of being prior authorized and subsequently paid once the actual claim is submitted. So when we're talking about physician documentation from your referral sources, you want to make sure you are working with your referral sources, especially those that you have good relationships with, to make sure that they are documenting in a way that gives you what you need to support your claim. The Dear Physician letters that are put out there and published by the DME Max are a really good resource to provide a general outline to your physician referral sources as to what Medicare's expectations are. The DME Max also have what are called documentation checklists on their websites that are available and are a good resource for you to use to educate physicians and provide the physicians with the questions they really need to be asking their patients so that they are documenting in a way that supports the ultimate claim that you are going to submit. Okay, some things to think about. Functional level comes into play in this situation with prior authorization because all 6 of the codes that involve prior authorization, at least initially, are K3 functional level codes, and that has to be well documented in the physician's medical records as well as yours. It's not enough to simply state my patient is K3. That's not going to hold water in either the prior authorization process or otherwise. You have to be able to show that there's documentation of the things that make that patient a K3 functional level amputee. The ability to vary their cadence, the ability to walk at more than self-selected walking speed, the daily activities of daily living requirements that they have that make them more than just your typical community-based ambulator. So you need to make sure and you need to work and educate your physicians on documenting in a way that shows, not only states that the patient is a K3 functional level. Okay, oh, went one too far there. Sorry about that. So the other thing that's important here is there is value and there is relevance in what are called either amended notes or addendums or additional information that clarifies what might already be in the medical record. While this is not ideal and this would be perfect if it was already there, we all know that the physicians are not always documenting with the thoughts of justifying the medical need for the prosthesis or the orthosis that they are prescribing in mind. So sometimes they have to go back based on your information, based on a therapist's information, based on other members of the rehab team's information, and amend those notes and add addendums into their progress notes to really bolster the support of the claim. So those need to be done properly. They need to be properly identified as addendums. They need to be properly dated and properly signed by the physician who is entering that information or the non-physician practitioner. Okay. Another thing that you can do is make sure that you are following and that your physicians are following the lower limb prosthetic medical necessity guidelines. These are going to be housed in both your LCD or local coverage determination and your policy article, both of which make up the medical policy that governs Medicare coverage of lower limb prostheses. There are basic coverage criteria that have to be met in every scenario. Those two basic criteria that should be well documented, they cannot be inferred, is that the patient is able to reach or maintain a defined functional level within a reasonable period of time, and the patient must be motivated to ambulate. Without documentation of those two conditions, you are dead in the water before you even start as far as coverage is concerned. So it's very, very important that this information is housed in the medical record and is not relied on to be inferred from other information in the record. Okay, basic coverage criteria must be documented in the patient's medical record. It must be documented by not only the prescribing physician, but also by folks that are involved in the care of that patient. So it could be prosthetist records. Luckily, we had a legislative change a few years ago that significantly increased the value of the prosthetist records to make that part of the official medical record. It can be records of therapists, other practitioners, and then corroborated with what is in the physician medical record. It is all a big picture item of what makes up the medical necessity documentation altogether. Don't limit yourself. Don't rely on just what's in your records. Don't rely on just what's in the physician's records. Go out to the full rehab team and get whatever information is available to make sure that you have the best opportunity and the best chance to have your claim prior authorized and subsequently paid. Okay, moving on to the next slide here. Sorry, it's not advancing. Oh, there we go. Talking about functional level classifications, again, the 6 codes are K3 requirements. I covered these earlier, but let's just go over them briefly again. The unlimited community ambulator, the ability or potential for ambulation with what is called variable cadence, which I said earlier is typically defined as the ability to walk at more than self-selected walking speed. That could be faster than self-selected speed. It could be slower than self-selected speed, but it's the ability to vary the patient to self-vary their cadence based on the environmental conditions and the ambulation needs that they may have within a given time. They have to be able to move and to ambulate beyond simple locomotion. I'm sorry. So up and down ramps is good examples. More than just walking up 1 or 2 steps. These are the things that need to be documented to show that the patient is indeed a K3 level amputee or more, frankly. Okay, next slide here. Let's see here. Sorry. There we go. Oh, I'm sorry. I went way too far. I apologize. We're running just a little bit lagged here. So in talking about the lower limb policy and coverage guidelines, again, it is a collaborative effort between the physician, the prosthetist, the physical therapist, and the patient. One of the things that you have to remember when properly documenting functional level is that it is not a subjective criteria. You have to be able to document the patient's functional level using objective criteria, meaning what is being observed, not as being what is reported. So it's not enough for the patient to tell you that they walk 3 miles a day, that they are constantly out in their community. But that is part of it. But then there also has to be observatory documentation of why the patient meets their functional level. So whether that is walking in your office, if you have ramps available, walking up and down those ramps, doing extended distance walking tests, observing the patient being able to vary their cadence during these tests. Those are all things that are very important to be documented. Okay. All right, I'm trying to advance here. Devin, can you advance the slide? For whatever reason, I'm having some trouble advancing these slides from my end. Thank you. So again, it is a collaborative effort that is not only within your criteria, but also within the documentation and within the information that is housed in the records of the other physicians, the other practitioners, the other members of the rehab team. Okay, so what you're talking about when you're looking at what type of, let's say, what type of foot you're using, what type of knee you're using, that is going to be based, according to the coverage criteria, on documentation and information that is housed in the records of both the prescribing physician as well as the treating prosthetist in this scenario. So your information, your records are certainly valuable here. And should be relied on in conjunction with what is in the physician's record as well. All right, so let's talk about some other requirements, and this is kind of a big issue that has come along as part of this process, although it is a little bit independent of the prior authorization process, and that is the PDAC coding verification requirement that actually went into effect as of August 1st, 2020. So for claims with the date of service, I'm sorry, no, forgive me, the coding guidelines that are associated with the coding verification went into effect August 1st of 2020. The actual code verification requirement as a condition of payment will actually not go into effect until January 1st of 2021. The PDAC is currently and actively working with manufacturers to make sure that submissions are submitted in time to meet this January 1st deadline. But the coding guidelines that were part of the most recent update to the lower limb prosthesis policy article for these 6 codes actually are effective as of August 1st, 2020, and can be used as part of the prior authorization process when the DME MACs are making sure that the products that are being provided are accurately coded. So there's a little bit of a lag and a little bit of a disconnect between the coding verification requirement, but as of January 1st, 2021, it will be a condition of not only prior authorization, but a condition of claim payment that any of the codes billed using, or any of the products billed using the 6 codes on the prior authorization list for lower limb prostheses must be PDAC code verified. All right, so another thing, and this is probably our last point on this issue, is what's called clinical inference. And this is an issue that really frustrates people quite often because a lot of times you assume that what you know to be true, everybody else involved in the process knows to be true as well. And that is what is called clinical inference. What that says is that a good example is that the patient has a prosthesis. Of course they're motivated to ambulate. Isn't that obvious? Well, that is clinical inference, and it makes logical sense, but from a policy standpoint, it cannot be relied upon when claims are being reviewed by insurance carriers and by the DME MACs. So the thing to remember here is that if it is not specifically documented, you cannot rely on it to show the medical need for a service or a prosthesis that you are delivering. So things like asking the questions, are you using or will you use a prosthesis to perform activities of daily living? Will you be using your prosthesis on a regular basis? These are things that are kind of what I call duh questions, but without an answer, without documentation, they cannot be assumed to be correct for purposes of medical review. So That's something that you need to be aware of. Another thing you need to be aware of is talking to your Medicare beneficiaries, talking to your patients, making sure that they are aware that despite everybody's best efforts, prior authorization may result, hopefully, in some limited delays in the delivery of their prosthesis or their prosthetic components, and that you are working with their physicians, you are working with the Medicare carriers and the contractors to do everything to make sure that there's not a unreasonable delay in delivering what we all know to be the very medically necessary prosthetic care. Okay, so with that, I think the next step is to kind of stay tuned. This is a moving target. Like Devin said earlier in the presentation, this process has been delayed once already. It has not escaped AOPA that 2 of the 4 states where this program is scheduled to be rolled out initially on September 1st, specifically California and Texas, have 2 of the highest rates of COVID-19 spread right now. And AOPA is concerned about whether or not this is really the right time to be implementing a new unfamiliar program when providers are already struggling with maintaining staff, maintaining normal operations during a active and sometimes increasing public health emergency. We have gone on record with this concern. We have formally requested a continued delay in the prior authorization program for lower limb prostheses to CMS at the highest levels. We will be following up with them, as we have not had a response as of yet, but we will continue to pursue that. We will be performing several Q&A sessions that will give folks the opportunity to ask and have questions answered live with AOPA staff and AOPA experts. Those will be happening, and those will be scheduled in the near future. So keep your eyes open to see when those dates are scheduled and when those dates are available. Like I said, there will be multiple opportunities. We will continue to communicate any information about prior authorization as we receive it, including any information about how the code verification process is going, how it will work, when products are added to the product classification list and are code verified. And AOPA is also, like I said, working with our manufacturer partners to assist them and support them in their submissions and their work with the PDAC to make sure that their products are listed and code verified by that January 1st, 2021 deadline. So with that, I am going to give Devin back the program, and he will give our closing comments and remarks on the topic, and hopefully this is good information that you found useful in preparing for prior authorization.
Thank you, Joe. As always, it's a pleasure to have you aboard for these discussions, and thank you everyone for listening in this, and we hope to see you register and take part in our upcoming live Q&A sessions. With that, we'll go ahead and close it out for everyone. If you have any questions, feel free to reach out to Joe or I before the Q&A sessions or at any time. Thank you. Have a great day.
Have a great day, guys.